Dr. Mensah is a clinician scientist who currently serves as the director of the Center for Translation Research and Implementation Science at the National Heart and Lung and Blood Institute as part of the National Institutes of Health. Welcome, Dr. Mensah.
Thank you very much, Bindi. You did very well. Our names are very long. The center name is very long, so we tend to abbreviate it and call it CITRIS. And the National Heart, Lung, and Blood Institute, we tend to call NHLBI. And of course, everyone knows the NIH. So thanks for the warm introduction. I will turn my, try to share my screen now. And I believe this is the screen. So Mindy, could you tell me if you've seen my presentation in presentation mode?
Indeed we do, we see you and your presentation, that's good.
Excellent. So let me thank you again. This is a real privilege for me to be with you this afternoon. And I really want to thank the foundation for seeing it necessary to support an activity like this. This is a critical time during the pandemic, and many of the lessons we've learned from the pandemic regarding disparities are so important that it's really worth talking about. And I also want to thank all of you because I'm sure you have multiple other competing priorities, other important things that you could be doing. So it's really a privilege that you've chosen to spend that time with us here. I definitely wouldn't spend all the time talking to you. I would want to give some basic facts, some of which you know already, but they may be important enough that they're worth repeating. And then we use that as setting the table. And I'll make sure that we have enough time at the end for addressing questions. Now, I'm here representing the NIH-wide Community Engagement Alliance. This is an alliance that was formed specifically to address COVID-19 disparities. What we want to talk about is really the health disparities and the impact of COVID-19. I should mention also that, of course, I had the opportunity to go to the website for the foundation, and I was certainly very pleased to see the number of activities that the foundation supports. So kudos to the foundation for sarcoidosis research, and especially for the survey that you're sponsoring. It always makes a big difference if you actually go to the public, you go to patients and their family, and ask what's important, and then use that information to inform what we do. So I was really pleased to see that. I also saw they had a special section on women of color, a very, very important segment when you think of all sarcoidosis patients, and of course the section on COVID. So all in all, I'm really very pleased to be here. This is my disclaimer and disclosure statement, and it's important that you know that I have no conflicts of interest at all. I don't receive a stipend for giving this presentation. I'm doing this as part of my official federal government work. So in essence, some of your taxpayer dollars have paid for me to spend the time with you. So please don't hold back. Send forth all your questions, and if you have ideas and suggestions for how we can serve you better, I'm also willing to hear that and take it back to my center and my center leadership. This is the alliance I mentioned just a minute ago, is the Community Engagement Alliance. We call it SEAL, spelled with a C, and specifically designed to work with communities in the fight against COVID-19 disparities. Not just COVID-19, but specifically the disparities of COVID-19 that impacts our communities. You can find a lot more information than you hear from me tonight by going to covid19community.nih.gov. So again, it's covid19community.nih.gov. vaccine.gov. And that's the only public service announcement I'm going to make tonight. We provide funding for teams in 21 states, including the district and also Maryland and Virginia. And the ones highlighted in blue are the original 11 states we first funded last year when we were at the peak of the pandemic. And then we had the opportunity with additional government support to fund some more states. So depending on how we do, may be able to extend to other states. But the real focus of the work is to partner with academic health centers and especially community-based organizations, faith-based organizations, state and local health departments, as well as pharmacy and other health networks in a way of extending and reaching people in the communities. It's important to begin with this slide. It just reminds all of us how important COVID-19 is. The colors reflect the total number of cases in the top and the 28-day cases, meaning the past month in the bottom. And you see that we've already passed 43 million cases. We've passed 700,000 deaths in the United States. And the green reflects the total of vaccinations. 395 million doses. We're hoping to do more. Right now, averaging 28-day vaccine doses, averaging slightly less than 20 million doses. What I wanted to point out in this slide is if you look at the figure that I'm showing, and Mindy, could you just give me feedback? Are you seeing my mouse?
We are, yes.
Excellent. So you see there is some good news to share, actually, because the total number of cases seems to be coming down. The weekly deaths also seem to be coming down. This is at the national level, but the vaccination rate is not as high as we would like. So whether you hear this evening for yourself, for your loved ones, for other family members, or as a general public member, I hope that by getting your questions answered, you may become convinced of the safety of this vaccine so that if you haven't been fully vaccinated, you go ahead and get fully vaccinated. And when you have questions from your colleagues, your friends, your family members who are not sure about the vaccine, that you can answer their questions and help them make the informed decision to get the vaccine, because that's how we really get back to normal. I've been asked to address the disproportionate impact that COVID has had on communities of color. And what I've done in this slide is to show you some data from the Centers for Disease Control and Prevention, CDC. This is from November last year. In columns, the race ethnic groups. So the column I'm highlighting now is the American Indian, Alaska Native. If you look at the Black and African American, or you look at the Hispanic or Latino persons, you see that whether you look at cases or hospitalizations or deaths, there's been a huge and disproportionate impact in these communities of color. Almost a 4-fold increase in hospitalizations when you look at American Indian and Alaska Natives compared with whites. If you look at deaths, a 2- to 3-fold increase in Black or African American or Hispanic and Latino compared to whites. So this is really important that we take these communities seriously, that we do our best to improve access to preventive measures, to the vaccine, to treatment options, so that we stop losing people. Really, really, really important. Now, very often when we show these slides, we all know that we're talking about adults, and that's what the message has been predominantly. But actually, the same thing is seen in children, in adolescents aged 12 to 17 years. I'm showing you here the number of cumulative hospitalization rates. That's a number of hospitalizations for every 100,000 people, segmented by non-Hispanic whites. So for every 100,000 whites back in March through March 2020 through April 2021, for every 100,000 white people, you had 2 hospitalizations, but in blacks, you had 10 to 11 hospitalizations, almost more than a 5-fold increase, and it's worth nearly 8-fold increase in Hispanic or Latinos. So really a disproportionate impact in communities of color. These children from communities of color. If you look at deaths, as I mentioned in this chart on the left is hospitalizations, but you look at deaths, it's actually the same story. Here we're looking at the 121 deaths that were reported to the CDC in young people less than 21 years of age. Only about 10% of them were infants. The majority of them were aged 10 to 20 years. So in this group, 80% of the deaths from COVID were in people of color, Hispanic, non-Hispanic Black, and non-Hispanic American Indian or Alaska Natives. Approximately 40% of the population, yet they make up 80% of the deaths. So the disproportionate impact is real, and we have to take it seriously. Now, it's another way of looking at it. It's the same story. Here we're looking at the rate of COVID-associated hospitalizations, different time period from March to November, but you see substantially much higher rates in American Indian, Alaska Natives, in Black Hispanics compared to white and Asian Americans. It's important that anytime we show data like this, that we emphasize that it is not because of the color of their skin, but really because of the interplay of a multitude of things, the clinical characteristics, the socioeconomic status, the environmental determinants, the type of work they do. All of these collectively puts minority communities at the higher risk for COVID-19 complications. This figure at the bottom here tries to tease some of them out. I'm sure many of you have heard the term. When it comes to health, your zip code may actually be far more important than your genetic code. The neighborhood characteristics really have an impact on health. Then you add onto it the lack of access that many of our communities of color suffer. Then you have high exposure because they are in essential service. They don't get to stay at home and telework and get paid. They have to be out there and exposed more often than other communities. And especially because of underlying health conditions, whether it's sarcoidosis or high blood pressure or diabetes or treated cancer. So it's really important that when we think of the disparities and the disproportionate and huge impact, we don't just think that it's just a black-white thing. It's really a multitude of social, environmental, policy-related issues, and we need to work at the root cause of these if we're going to be successful in eliminating the disparities. This is a chart just to summarize it, to say that the social determinants of health are very important. And very often when we say racial differences or ethnic differences, what we're really talking about are the different differences in healthcare access and the quality of care that people get, how the neighborhood is built and how they're different, the social and community context and support, as well as the joblessness and the economic instability, education, all very important. But anyway, you all know this, but I think it's worth emphasizing. The final group I want to highlight, particularly when we're talking about sarcoidosis, is African-American women. No matter how you look at it, there's a huge burden that African-American women carry, whether you're talking about the incidence of sarcoidosis itself or how common the prevalence of it in the community, or the hospitalization rate, as much as 10 to 18 times higher than in whites, and even double that of Black African-American men. And when you look at the mortality rate, it's also much higher. So it's really very important. Having sarcoidosis as the background provides a framework for taking all of health very seriously, not just as an individual person or an individual patient's burden, but our society's burden, NIH's burden, our responsibility to do the science and translate the science for the benefit of the patients, and especially those who carry the highest burden, like in African-American women. I put this slide in here just to show you how little knowledge we have of the challenges of sarcoidosis, its management, and especially the intersection with COVID-19. You're probably going to have lots of questions for which I may not have definitive answers, but I'm eager to have that dialogue, and there may be a lot of things I'll learn from you. But even for such an important scientific paper just published September 9th, there was no mention of COVID. And I suspect Dr. Drent and his colleagues knew that several of the things we think about, we don't have definitive evidence for. And so we really need the research. And so whenever you have the opportunity to participate in research involving persons with sarcoidosis, I hope you will consider it. We are very eager at NIH to support research so that we know more, but even better than that, that we don't just take the knowledge and publish it like this and leave it on the shelves, but that we take that information and work with communities in community engaged research so that people can benefit, live longer, and live happier lives. Here are a few things that I want to answer because they tend to be the more common questions that come to us a lot. So for example, patients who have sarcoidosis more likely to get COVID-19. And the foundation has actually done quite a bit of work in it, and I'm hoping that the survey that you have would also provide additional information. But there's really no current compelling evidence that the presence of sarcoidosis by itself inherently puts the patient and makes them more susceptible to COVID-19. Now, I would explain a little bit later, because when you look at the evidence that we have, it looks like sarcoid by itself, without any underlying comorbid conditions, without any underlying organ involvement, without any underlying complications that require particular treatment, that disease by itself does not necessarily predispose you to having COVID. But it's really important to take it far more seriously when you have an underlying condition, or when you have a complication, or when you're under specific treatment. And the other question is, do sarcoidosis patients get more severe COVID? Maybe they may not be at increased risk, but once a person with sarcoid gets COVID, their disease is more severe. And again, the response is, it depends. And it really depends tremendously on the underlying comorbid disease. Do they have lung involvement in the sarcoidosis? Do they have high blood pressure that is not controlled? Do they have heart failure or other heart disease or diabetes? Are there other organs involved in their sarcoidosis? And certainly older individuals, particularly age over 65, where very often other comorbid conditions also come in, these all become important. I have highlighted immunosuppression because while immunosuppression is very good in controlling sarcoidosis, it may predispose you in settings when you get COVID that you may have more severe COVID. But this is where your doctor comes in. And it's extremely important that you have that doctor-patient interaction, that you speak with your doctor, and you know how your medications are adjusted or managed so that you have a much better outcome. In general, unlike rituximab or steroids, methotrexate and tumor necrosis factor inhibitors are not likely to be major predisposing factors to severe COVID. It's really when you have substantial immunosuppression or very high dose steroids, greater than 20 milligrams equivalent of prednisone, that then you and your doctor need to have that conversation to protect you. This I found as I was going through your website, and I put it on here to say, particularly those of you who are not familiar with the Foundation's website, it has really very useful, very trustworthy information. This to me was black and white, very simple. Green, yellow, red, traffic light approach. Patients with sarcoidosis recommended to get the vaccine? Absolutely yes. So if you haven't received it, you may have a reason that you haven't received it. I'll be very happy to hear it, and we can address some of the questions. The questions will be posted anonymously, so they don't need to be identified with it. But is there a concern that if you have sarcoidosis and you get the vaccine, you will get a flare-up? There we also have compelling evidence that says no. Where we're not sure because we don't have enough information is how much of a response every patient or any one particular patient who has sarcoidosis gets a response to the vaccine. But in general, there is a response. You are protected. We may not be very sure how long the protection lasts, which brings in the issue of the booster. But without any question at all, having COVID is worse than the risk of not having COVID. It's really important, therefore, to take the vaccine. The side effect from the vaccine or any adverse effects we know from the vaccine is much, much, much less than the outcomes from a person with sarcoid getting COVID. This is a result from the Foundation's survey with 292 people responding. And the good news is in this survey as of February this year, nearly 2/3 of the people who responded had gotten the vaccine, and only about 1/3 had not received the vaccine. And if you ask the subsequent question why they haven't received the vaccine, you see that importantly, again, it goes back to the social determinants of health that we mentioned. 21% of them were not able to get an appointment. Another very small percentage didn't have transportation to get the vaccine. Others had other reasons for not getting the vaccine. But we have to recognize that there is still a substantial proportion of individuals who have safety concerns. And I really want to hear about that, because for a lot of the concerns around safety that people have, we have true, legitimate, factual responses that most people, after hearing the responses, would change their mind and get the vaccine. The types of symptoms that you get are not very different from the symptoms you get from other vaccinations. The fever that you get in a day or two, feeling fatigued, having a flu-like symptom, all these percentages are shown here, and other symptoms that may be more rare. But the sore arm at the site of the injection is probably the most common, and all of these go away. I'm not very fond of needles, but I got my 2 shots, and I can say I didn't feel a thing. So I strongly recommend it because all the evidence suggests it is really worth getting. Now, because of the safety issue, I put in this slide so that we can go over one of the main reasons why some people have doubts about the safety of the vaccine. What I used to hear a lot last year, and even I myself had that question is, in general, it takes 7 years or longer to develop a vaccine. So how could the COVID vaccine be developed in such a short time, 10 months or so? And if it was developed in such a short time, did they cut corners? Is that why we're able to get it out so quickly? And the answer is absolute no, and I'll tell you why. Usually, you do all your bench research and you identify something that looks like would be a good vaccine. So you have to do what the FDA calls a phase 1 study. You recruit about 20 to 100 healthy people, and you ask the question, is the vaccine safe when I give to these 20 to 100 people? Why is it only 20 to 100? Because if it's not safe, you don't want to expose 1,000 people to it. So phase 1 studies are very small, very carefully done, and you check to see when you give them the injection, do they take it well? Is it safe? Any serious side effects? How does it relate to the side effects? Is it right away? Does it take a few days? So there's a lot that we learn from just only 20 to 100 people, but it still takes about 6 to 8 months to complete. And in the past, you would plan the study, recruit your 20 to 100 people, give them the vaccine, and wait 6 to 8 months before you get a result. And if the results suggest that it's safe, then maybe you publish it, you get a lot of criticisms and you improve things, then you start planning for phase 2. And in phase 2, you need several hundred, maybe 300 or 500. And in phase 2, you ask the question, what are the most common short-term side effects when the safe vaccine is given? And when it's given, how does the body react to it? What is the nature of the antibodies that it produces? And are there signs that it will be protective? So you need to plan for time to recruit several hundred people. And that could take, a year to 2 years. You add it to phase 1, you're ready at 3 years or more. Now, phase 3 is the kicker because you've shown that it's safe, you know the side effects, you know how much to give. So now you recruit 1,000 or more volunteers, and half of them you give the vaccine, and the other half you give a placebo, and you watch them to see how many develop the disease you're trying to prevent. And you can imagine it can take 2 to 3 years before enough cases happen. So you add 3 years in phase 3 to 2 years in there, it's 5 years. And phase 1, that's 6, 7 years. But in COVID, because it was a national emergency, we did things in parallel. We didn't wait for phase 1 to finish before phase 2 and then phase 3. In fact, we started planning phase 2 when there was very good evidence that phase 1 would work. And at the same time, also plan phase 3. But the best part, that saved us the most money and saved us the most time, I should say, not money, is that instead of recruiting 1,000 or 3,000, we recruited 30,000 or 40, 45,000, so that instead of waiting 3 years, you could wait 6 months and you have enough events. So because these phases were done in parallel and not one after the other, you were able to truncate the time. The only thing you lose is you put a lot of money into recruiting 40,000 people and administering the test and doing all the planning, all the people you pay to do it, if it turns out that the phase 2 study doesn't work out. But all you lose is money, but safety is never a shortcut. And the federal government guaranteed the industry so that they didn't lose money either. That's why we were able to get the vaccine out very quickly. So if anybody tells you that because the vaccine was produced very quickly, it must not be good, please tell them that is not correct. Safety was always the first priority. And even after the phase 3, we continue to monitor everyone, particularly for conditions like sarcoidosis, where we may not have enough sarcoidosis patients participate or have the vaccines early. We need to monitor long-term. so that we can learn more about side effects and adverse events. Some of you may have questions about the coronavirus variants. The variants are very important. They're also very important in the sarcoidosis community because variants happen when the original virus undergoes mutation. What it means is, for example, these spikes contain proteins, and if there's a mutation in the spike protein, that mutation then makes the virus a new variant. That new variant may become more contagious or less contagious, or it may be more susceptible to a vaccine or less susceptible. And it may be able to evade our strategies for treating it. So variants are very important. And so anything we can do to stop the development of variants is really key that we must do. And the best way to do that is having most people in the community get the vaccine. Because if everyone is vaccinated, the virus doesn't have too many places to go and to replicate and to mutate and to develop a variant. So when we have widespread vaccination, we have the best opportunity to stop the development of new mutations. You probably all heard about the Delta variant. That is the most common variant in the United States right now. Why is it important, particularly to people with sarcoidosis? And this chart helps. So this is originally, you may recall, we used to call the variants by these strange names, B1.6, 17.7. Nobody remembered any of that. And so the World Health Organization helped us out and said, let's give them these names. So the B.1.617.2 became the Delta variants, much easier. But this is what is important. How transmissible is that new variant? Meaning, how contagious is it? Is it able to evade or dodge our strategies for containing it? And how does it respond to the vaccine? So if you look at the Delta variant, it is 2 to 4 times more contagious than the original ancestral virus. And that's the reason why if you are in an area where the Delta variant is the most predominant variant, which is what we have in the United States today, you really have to take all precautions. Get your vaccine, wear your mask when you're in groups, keep your distance, and really avoid crowds, particularly the crowds in indoor spaces. Because in spite of being fully vaccinated, you still could get infected, particularly if there's a lot of Delta variants floating around. But there is good news. And the good news is all the variants respond to the vaccines that we have. And so the worst thing you can do for your loved ones, or for yourself, or for your friends, or for your community is not getting vaccinated. So really, please, 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 unless your doctor has told you you have a contraindication to the vaccine, everyone really should get the vaccine. Getting towards the end here, here are some valuable sources of information on sarcoidosis and COVID from the Foundation's website. I already showed you our NIH website, but you can also go to the CDC website. Again, I particularly liked the emphasis on African-American women and the sarcoidosis campaign. The website also on COVID-19 and sarcoidosis was also very, very useful. And here's how you get to all of them. This is a chart, and all my slides are going to be made available to you. Mindy, you can share it with everyone. I'm not going to go over everything here, but I just want to let you know that I have a lot of details about the 3 types of vaccines that are approved, the dose that is given, how often you get it, whether it's a 2-shot vaccine or a single shot, as in the J&J vaccine, and who are the people who participated in the trial. What proportion were Hispanic or African American? All that information I've provided here, and you can look at it when you have some time. But I wanted to summarize it on this slide. If you look at the Pfizer in the dark blue, the Moderna vaccine in the light blue, and the J&J or Janssen vaccine in the much, much darker color, as you see, almost a 9 to 10% participation for the mRNA vaccines, Pfizer and Moderna, and about 20% in the Janssen. Janssen recruited abroad also, so there were some recruitments made in South Africa. Same thing in Hispanics, there were recruitments made in Latin America, and that's why the Hispanic and Latino populations were high. But in general, people like me participated in these vaccines, and I think we all should feel very comfortable that they are safe. The next 3 slides just break them down. So for those of you who want more information, this would be in the back. You can take a look at more data, the number of years, how old were the people who participated, and whether or not they had comorbidity. And I've done that for the Janssen vaccine. I've done that for the Pfizer vaccine and also for the Moderna vaccine. Here, let's address the question of the boosters for those who are immunocompromised. And again, I want to emphasize the fact that someone has sarcoidosis by itself does not automatically make them an immunocompromised person. It's important to speak with your doctor. Ask about your status. Ask about your need for the booster. Of course, ask for the need for the vaccine. I'm sure he's going to say, yes, get it. And then ask about the need for the vaccine. Really important to maintain the relationship with your doctor. Important to know, though, that if you are receiving any of these treatments, high dose steroids, that's at least 20 milligrams or more of prednisone in the last 2 weeks, and you got your vaccine around that time, you are likely to need a booster, because the immunosuppressive treatment, even though they work great for the sarcoidosis, prevents your body from mounting a full immune response, meaning you don't generate the same level of antibodies to fight COVID as someone who's not on immunosuppressive therapy. And that's the basis for the booster, not that you just have sarcoidosis. I want to conclude by saying that even though I'm delighted to come and visit and spend time with you, I was very pleased to see that you already have a speakers bureau at the foundation and several people of color who participate in the foundation. I hope you take advantage of listening to them when they are given these seminars. And here at NIH, we truly believe in diversity and inclusion. Several of our leadership who help support research are people of color. People who do the research include people of color. We have individuals like Dr. Lisa Cooper, who is a distinguished professor at Johns Hopkins, sits on data safety monitoring boards to make sure that people who participate in the clinical trials really getting the best care, they're receiving research approaches that are consistent with the current policies, so that you don't have the sorts of things that happen during Tuskegee. But the real message is we are on the scientific pathway, we are part of the research, and it's really important for our people, our communities, to also trust the vaccine. Let me sum up everything I've said in just 10 points. The first is that there is no question at all that COVID has had a huge and disproportionate impact in communities of color. This impact has not just been on adults, it's also been in children. And that's why we have to take COVID seriously. If you take the case in all persons, including those with sarcoid, having an underlying clinical condition, whether it's heart disease or lung disease or cancer, whatever the underlying disease, it should tell you that you are at increased risk. And therefore, if you haven't gotten your vaccine, please, please, please talk to your doctor, get the vaccine so you can protect yourself and your community. It's not the color of the skin that predisposes people to this high risk. It is the interplay of the clinical characteristics, the social and environmental determinants that puts them at risk. And so we need to address these social determinants. They are at the core, the root causes of these disparities. We mentioned the high priority and the high burden that African American women experience. So anything we can do to contribute to the research, to the education, to the awareness, and to the support, that's what we need to do. And I say we, it's a collective we. We at NIH recognize that, and we're doing that. But policymakers, everyone, we all really need to take that into account. Right now, we don't have compelling evidence that sarcoid by itself makes people more susceptible to COVID or to more severe disease, but having underlying conditions would definitely do that. The vaccine is definitely recommended. The final three is patients who have sarcoid and are receiving immunosuppressive therapy, including high-dose steroids, and the elderly really should get a vaccine, and they should talk to their doctor about the booster. Certainly treatment within the last month with immunosuppressive drugs, if that's the time you got your vaccine, is a very, very strong indication according to the CDC for getting the vaccine. But in all instances, always, always, always talk with your doctor and your healthcare provider first. Mindy, I think I'm going to stop here. I'll go to my other screen and try to stop sharing so we can get back.
Excellent. Thank you so very much, Dr. Mensah, for that excellent presentation. I have to say, it was one of my favorites so far, so thank you so much for that. I would love to encourage folks to drop their questions in the Q&A. As you might have noticed, the chat is one way, so I was able to chat with you guys, and I posted some of the websites that Dr. Mensah mentioned during his talk are in the chat, and we'll make sure to send those out with the PDF version of Dr. Mensah's slides in the follow-up email after this, which will also include the recording. So hopefully if anyone's got that question on their mind, that's been answered. We do have a question about how can faith-based organizations get funded, or are there pathways to sort of further the work in addressing some of these disparities?
A very important question. In the past, when we've talked about biomedical research, we've tended to focus on academic health centers and research centers, and not as often focused on community-based organizations. Also in the past, when we've even thought about communities, we go into the community, we do the research, we finish, we take our data, and we go back to the ivory tower. I think all of us have realized that that's the worst thing we can do. So in SEAL, we specifically focus on community-based organizations. So if you go to our website that I showed and you have in the link, every state where we have a SEAL team, we have a link that will show you who the SEAL team investigator is. It would also show you which community-based organizations we are already working with. Maybe we're working with your community-based organization, and you might have been busy and you didn't know it. But if you want to connect, that is the easiest way to connect at your state level. We are not in every state, and so if you know of a SEAL team next door, connect with that team or find out if that is feasible. Finally, it's very likely that in the future, there may be programs that enable us to work directly with community-based organizations. When that happens, we make sure that all community-based organizations know. I should also say that the CDC has programs that work directly with communities. I used to be at the CDC for 9 years, and we helped build the heart disease and stroke prevention program. And there is a racial and ethnic approaches to community health, a strong link with communities. The prevention research centers also work with communities. So There are lots of resources. I'll strongly encourage you to begin with our website, but then go to the CDC website and check on community-based organizations, and you would find a good place to provide your support and research.
Thank you. We have another question about how can I best speak to my friends of color about being vaccinated if there's vaccination hesitancy?
Very important. Maybe the way to frame it is, how do I listen to my friends who have hesitancy? Because very often, those of us who are already convinced, we are very eager, just like I just did. I talked to you for 30, 40 minutes. Maybe I should have just opened the mic and I listened to you. I think the most important thing is really listen to them. Why are they hesitant? And show some empathy. They may have a very good reason. They may have been an experience that is making them concerned. Maybe it's a legitimate safety issue. Maybe it's something about an underlying condition they have that you don't know about. But if they're willing to talk and you hear their reasoning, you'll be in a much, much better place to then speak with them or share with them a resource that can answer their question. And so hesitancy comes in many, many different forms. There are people who are hesitant because they say, it's my faith. My faith says I can't have a vaccine. Actually, some of them, if you ask, they're not sure what faith that is, but it doesn't make any difference. Just listen to them first, and then try to get to the basis of why they're hesitant and point them to trustworthy sources and share with them. But the one response you can always give, if it's a matter of, well, you know, I'm not sure it's safe, let them know that in the United States alone, we've given nearly 400 million shots, and all of these people are alive. That's point number one. Second point, right now in the United States, most of the people who are dying in hospital with COVID tend to be people who have not been vaccinated, 99.9%. It's really a sad story. So I wouldn't want to lead with that first. The important thing is the vast majority of people who get vaccinated, even when they get a breakthrough infection, they have a mild infection and they don't end up in the hospital. So it's the best way to protect your family and your friends and your loved ones.
Thank you. We did have some questions submitted ahead of time through the registration process, and I want to get to a couple of those. And this kind of leads into what you were just saying regarding breakthrough virus, sort of breakthrough cases after getting your vaccine and being double vaccinated. Are people of color or communities of color seeing higher levels of breakthrough infections, or is it, where is that?
We have no compelling evidence that that's the case. Now, if you were to ask the question slightly differently and say, are frontline workers more likely to see breakthrough infections? Then I would say yes, because the exposure is higher. So if you take a white male who is a frontline worker, either food service, restaurant, or works in the hospital, and fully vaccinated, their risk of getting a breakthrough infection is much higher than African-American women who teleworks from home, right? And so that's an instance where clearly the risk is related to the exposure. Another example is two people who are vaccinated. One person says, I'm vaccinated, I'm immune, I'm not going to wear the mask. Doesn't make any sense. And so goes everywhere without a mask. And another person who's also vaccinated, but always wears a mask. I can tell you from theoretical thinking that that risk is lower where you wear the mask. So we never like to use ourselves as examples, but my wife and I always wear a mask, even when we go out jogging. Because even on the path, we're crossing maybe up to 50 people each time we go on a 5-mile walk. So, you know, it doesn't cost me anything to wear the mask. And if I'm at a place where it's just the two of us, then I can pull the mask down so I can breathe better. The response is breakthrough infections, nothing strange. The vaccine is not designed to be 100% protective of you getting an infection, but what they're good for is they're almost 100% protecting you from dying. And that's why we all need to get it.
Thank you. Great answer. Thank you so much. We did have another question about, so what factors have we found to be the most challenging concerning COVID-19 in communities of color? And I know you mentioned sort of social factors, but are there any other sort of factors, and particularly factors that individuals in the audience can help address?
A very, very good question. And I'm also glad that you prefaced that with a social determinant, because the social determinants are important. And whenever you sit on the school board or you're part of the local council, always make sure that we don't do things like put a testing center far away at the medical center where you need a car to drive to go get it, right? Those are social determinants. We have to think about those. But beyond the social determinants, a really important factor, particularly in communities of color, has to do with mistrust of science. And the mistrust has a legitimate basis. If you think of what happened in the past, why can I trust that this research you're really doing in my best interest? And the reason people listening this evening can be of real service to our country is that because of what happened in the past, there are policies in place today that prevent those things from ever happening. And so there's every good reason to trust the science and participate in the science. And for those of us who are career public health people, that's the only reason why we're here. Now, if someone is not explaining something well, that's a different story. You have every right to ask that it be explained to you better. If you've been asked to participate in the trial, you have the right to have the protocol given to you. You have the right to have the consent form so you can go home and read it and then come back later. Nobody should be forced to sign the consent. And the best part is if at any time at all you change your mind, you can stop. And finally, if the research is placebo-controlled and halfway through the study, we find out that the treatment is actually really, really, really good, we don't continue giving other people placebo. We stop the test and everybody gets the study. So please remember that when somebody says, I don't trust the science, they may have a very good reason why they don't trust the science. Listen first and then give your response that, that is true, but I hear there are appropriate policies that have been put in place. And if you go to the NIH website and you put in clinical trials for patients, we'll pull up a link where you can watch a video about this.
Excellent. Thank you so much. I want to give folks one more chance to add any questions into the Q&A. Dr. Mensah really got a lot of these questions that were submitted in advance. You really covered them through your sessions. So we didn't have very many about that. We do have another question that just came through. Let's see here. Okay, so first, this audience member says, thank you for the presentation. Thank you so much for the presentation. She lives in Utah and it's very discouraging there with COVID. Most people there don't wear their masks. What is the current guidance for wearing a mask? And is it still recommended to isolate for 10 days after an exposure?
Very good question. Unfortunately, it varies by state and it varies by community. Some states have a mandate and the mandates actually are not the same. And so I think, and I should add that sometimes you put yourself at risk when you try to insist that other people follow the mandate. So my advice to you is first be on the lookout for CDC advice on the booster, so that if you need the booster, please get the booster. That gives you the additional benefit and the additional protection. And then the next is always wear the mask, keep your distance, and 10 to 14 days If you have the luxury of doing 14 days is better, but 10 days is fine. The one thing that has changed that is substantial is the physical distancing for children. As long as mask and hand washing is being done, you don't need 6 feet, and that 3 feet is good enough. But other than that, when it comes to COVID, the more conservative, and maybe conservative is a wrong word, when it comes to going all hands on board, vaccine plus mask plus hand washing plus physical distancing, and you'll be fine.
Thank you. We do have one question regarding Moderna, and so this person got their Moderna vaccine in January and February, and they're wondering when a booster might be available for those who receive Moderna. And you may not know the answer, but put it out there.
Yes. The evidence is only out for the Pfizer definitively. We know that the studies are being completed, and so we will have it from Moderna. I would say it's not a bad idea to just bookmark the CDC COVID website, and as soon as any news come up, you'll be the first in your community to know. But the good news is, honestly, if you had your 2 shots from the Moderna, you are protected. Now, depending on your age and depending on your underlying conditions, and if it's the same person who lives in Utah and there's a high exposure, then you may want to get it as soon as the information on Moderna is out. The one thing you don't want to do is, we are not recommending mixing it. There's a study on testing the question whether if you had Moderna, can you get the Pfizer now that it's approved? And the answer is probably should wait because we don't have evidence for that. Probably is good, but yeah, it's better to wait. I think you're fully protected for another several weeks before the announcement comes out.
Thank you. So we have just one other quick question, and if you can remind us, how long is it recommended after your second vaccine to get the booster? Is it 6 or 9 months for the Pfizer? Well, Pfizer is only recommended at this point, so that one.
Yes, I thought it was 8 months, but that's what I remember. But I can also double check that. The way my mind was thinking about it is we really don't have the real definitive statement, and even the CDC advisory panel recommendation was slightly different from the CDC director's recommendation, which aligned with the president's. And I think we all got aligned. I think everyone is trying to do the right thing. In general, I would wait until what your local health authorities tell you can do. And if you have underlying sarcoidosis or you have an underlying chronic disease, I would say give your doctor a call and ask your doctor, how long should you wait? And are you ready for that vaccine? And I'm really glad you asked that question.
Excellent, thank you. That kind of led into the next question, was if it's necessary to get a booster, and you had answered that earlier as well as just now. In fact, if you're not sure, definitely contact your doctor and who knows your medical history and can give a better answer for that. So Dr. Benza, I want to thank you so very much for coming and spending your time with us and putting together this wonderful presentation. It was really, really excellent. And we're very excited to share it out as a recording after this. And I hope you have an awesome day.
Well, thank you. I really enjoyed it. And it's too bad I'm not there in person, but I know it's the right thing to do in the COVID era. Maybe very soon when we're out of COVID, we may have a time to be in person. And I thank all of you for spending your time with me. Have a wonderful rest of the day.
Thank you so much. We would love that.
Thanks.
Bye-bye.
Bye-bye.